A really warm welcome to everybody for Healthwatch Oxfordshire webinar in March. Today's focus is going to be on supporting mental health and wellbeing in our children through their teenage years, and we're really pleased today to have Katie Jones and members of her team who will introduce themselves. Katie is Deputy Team Lead of the South Mental Health Support Team, and she's going to share some slides and talk about the work and the support that they do. As I said, we'll have a chance for questions at the end. You can put your questions in the chat, or you can raise your hand and we'll come to you. So really welcome, and really looking forward to hearing about this important topic. So over to you, Katie.
Thank you so much. Good afternoon, everybody. I have got a couple of my colleagues joining. Holly is here as well. Can you hear us now, Holly?
Yeah, sorry. Took a little while to get into the call, but I'm here now. Thank you.
We had some initial technical difficulties, but hopefully we've overcome those. And I'm hoping that Taja is going to join us as well in a little bit. So yes, if everybody's ready, we can get started. Holly, I think you're up first.
I am,
yeah. Start off by telling us a little bit about the MHST and what it is.
So hi everybody, I'm Holly Chivers and I'm the Service Manager for the Mental Health Support Teams in Oxfordshire CAMS. So we use the acronym MHST for short throughout this presentation. Can everybody see Katie's slides there? Yeah, I can see some nods, great. Thank you. Okay, so what is MHST? So back in 2017, the government developed a green paper, and really the purpose was to transform and expand children and young people's mental health care. And they based this on a school and college model. And in Oxfordshire, we're covering around 60% of schools at the moment, which is good compared to the national average. And we're predominantly in our primary age schools, and we are in some secondary schools as well. And our MHST sits within Oxford Health, within our child and adolescent mental health services. So when we talk about our MHST and what a team looks like, it's made up of education mental health practitioners. And again, that's EMHPs for short. We have supervisors and we have deputy team managers. And the aim of the model is to deliver low intensity CBT informed interventions. And the basis of the model is thinking around how we can sort of get involved earlier for young people. And the reason the school model was adopted was really to think about how we can build those relationships with young people in a familiar and safe setting. The MHST features very heavily in the NHS long-term plan. And as I said, currently in Oxfordshire, we have 60% coverage. So what that means is since 2017, as further funding has been rolled out each year, we've successfully been awarded additional teams, and that's been in a staged approach. We started off in the city, then we moved to the north of the county, closely followed by the south, then the west, and then we've just added some more provision into the Southern Vale. So we have some coverage in all geographical patches, but not quite 100%. And the aim is that we'll be there at the latest by 2030. Okay, next slide, Katie. So this map here gives you a bit more of an overview of where we are across Oxfordshire at the moment. As I said, on the left there, it gives you the breakdown of the geographical patches. We know that Oxfordshire is a big and wide county, so we go right down to the sort of border of Berkshire and right up to the border at the other side of Banbury. Okay.
So, what do we do in the MHST? We are a low intensity service, and we offer interventions for mild to moderate mental health difficulties, which makes us different than the expectation that people often have of CAMS. Really commonly we have schools often saying to us, these are the children with the most need. And we say, yeah, and we can fully appreciate that we would want support for them. But actually the MHST takes a different approach, and we are starting to try and get ahead of the curve. So we are working with children and young people with mild to moderate mental health difficulties. And it's difficult to define. There's no very clear definition. But what we work on is an understanding that difficulties are new and emerging. So they are just coming about. They are not having a huge impact. So they're not wildly impacting the functioning of children and families. For example, a mild anxiety might impact a couple of areas, and we're noticing that it's new and emerging. So actually, teachers perhaps have only just noticed in the last month that a young person's perhaps struggling with answering questions in school, not really asking so many questions in class, might have missed a couple of days of school. The idea being that we can get ahead of these issues becoming really, really huge, and we can skill up schools and families and children and young people to know how to deal with these difficulties when they arise, so they don't get to that really extreme end where there is a huge amount of impact and there isn't very much functioning that is remaining. So we're trying to get in before things get too severe. We've got over here, moderate anxiety or low mood may affect people every day, but it wouldn't be all day, every day. It wouldn't be fully debilitating, and there would still be a reasonable percentage of life that these children and young people are able to continue living as usual. So as Holly said, we offer low intensity CBT informed. There's a whole heap of acronyms that we use within CAMS and within the MHST as well. I really hope that we don't slip into using them today, but if we do, please feel free to ask questions later about what they all mean. So our EMHPs that we have in our team are specifically trained to deliver low intensity CBT informed interventions that are evidence-based. There's a whole heap of dashes in there as well. So CBT, we know from the evidence, it is the recommended treatment intervention for depression and low mood, anxiety in children. And that's covered in the NICE guidelines. What has then happened since those guidelines have come out several years ago is low intensity versions of those interventions have come about and been tested and evidenced. So CBT full intervention could be around 20 to 24 sessions of work. And as you can imagine, that's 20 to 24 weeks that a young person is in treatment sessions, out of school for an hour, whatever. Someone very, very smart, or several very, very smart people, have taken the most effective elements of a full CBT intervention and made that low intensity. So those sessions are between 6 and 8. Sorry, those interventions are between 6 and 8 sessions, start to finish. And they really work on skilling up young people and families to be able to use quick and easy techniques to address anxiety and low mood as and when it arrives. I think that covers all of that. And resilience, coping better. Good, covered all of that. So MHST, what do we actually do? What do we actually help with? We've said low mood. We've said mild to moderate. We've said anxiety. So here are some of the things that often come up. So behavioural difficulties I haven't mentioned yet. This is one of our primary age offers. So when families are struggling to manage the behaviour of their children and young people. But equally, the flip side of that is when children and young people are struggling with something and behaving in a way that they are trying to share that message with families, we can do a little bit of work around just making sure that the adults around them are hearing those messages before it gets to a point where they're having to behave in a way that could be problematic or dangerous. Our second primary age offer is some intervention parent-based interventions for childhood anxiety. That can be around separation, generalized anxiety, some really kind of common phobias. We don't get very many of those, but we can do some work around that if it comes up. Mild to moderate anxiety in teens. So I've listed these already with children, so it applies to teens as well. So general worry, separation anxiety, and specific simple phobias. Then other offer in adolescence is mild to moderate low mood or depression. We can do some work around that, really working on activating behaviours for teenagers to, make sure that in their lives they are getting a sense of achievement, a sense of closeness, and a sense of enjoyment from what they're doing. And then these final four, a little bit less common, but we still absolutely can offer some support around sleep difficulties in the context of anxiety or low mood. So it needs to be alongside these other two as well. And that will be sort of an add-on. That will be some additional sleep hygiene work to make sure that there's nothing glaringly obvious that we could be doing that's not happening. Difficulties, problem solving in the context of anxiety or low mood. So I don't know if anyone can relate to having a really stressful day and just feeling like I just don't know what to do, because when your anxiety goes up, your problem solving comes down. So we can do some work around that as well. We've got irritability and anger, again, in the context of anxiety and low mood. And what we know is that in teenagers, particularly teenage boys, the low mood and depression will more likely present as irritability or anger. And then stress as well is the last one. So kind of low level anxiety. For example, school stress around exams, organising. We do a lot of transition work between primary and secondary, and we do a lot of exam stress workshops as well. We are not a one-size-fits-all service. We cannot do everything. As much as everybody who works for us would love to be able to help every young person we come across, there's a few things that we're not able to do. So total school refusal, and I hope you can understand that this is because a lot of these things on this slide come up and are not new and emerging. So in order to get to total school refusal, we've gone past that mild to moderate to severe, and actually that's quite a big amount of impact that this, whatever difficulty it is having. Self-harm and suicidal ideation. So we are a low intensity service. We do not have a duty system. We don't have the safety procedures in place to make sure that these young people are getting the support they need. There's a few others on here. So obviously severe depression, different than mild to moderate depression or low mood. A couple that I just want to point out. So things like PTSD and OCD. We would absolutely love to be able to do interventions for those, because obviously those young people are in need. But there isn't currently an evidence-based low intensity intervention for them. It's being worked on, I believe. But that's not something we're currently able to offer. There's a few others on there as well. So attachment disorders, not something that we have the skills to treat. I think that covers most of the things. Eating disorders, there's a different team that does that, which I think will come up in another slide in a couple of slides time. I'll talk to you, the next one. I'll talk to you through that. So how does our team work? So we have a couple of options, and Taja's going to talk you through the whole school approach offer in a second, but anything up to this point that I've discussed with you, any of our one-to-one intervention work does require a referral to CAMHS, because like Holly says, we sit within the NHS. And these referrals can be done by parents or the young person themselves going to the school, talking to our single point of access team, or talking to a GP. That will then be triaged and then kind of checked for suitability for the MHST, going back to those previous couple of slides. Is it something we can work on? Is it not something we can support with? There's more information on our website. You can absolutely just Google that, as you can see at the bottom there. But most commonly, the referrals that we get are from schools, from a mental health support lead or a SENCO in the school who's seen and who knows the young person and can comment on how things are going at school and the impact that these mental health difficulties might be having. My next slide, I really like this one. And I would just preempt it by saying that there is a reasonable chance this may have changed since the time it was created. This really is just to give a very visual depiction of why CAMHS is not one service. So CAMHS is very often referred to as a single entity, but it actually isn't the case in reality. So it's really just an umbrella term for all of these different teams that exist and operate. They're not completely exclusive from each other, because obviously we do have the links internally, but it very much is like different departments perhaps in a hospital. So, you know, if you were open to a hospital and you had a referral to a hospital, you wouldn't, you know, just go, oh, well, I'm open to the JR, because people wouldn't really know what that means. So you would say, actually, I'm open to the trauma rehabilitation team within the JR. So the same works for CAMHS. And you can see here at the bottom, we've got all these different entry points for GP, school and parent. Every referral comes into the SPA, so the single point of access. That team then does an incredible job at triaging that information and sending it then on to the different teams. What we can do is, between the teams around the outside, is just discuss cases between ourselves, and if needed, we can make those internal referrals. So I know, for example, we work quite closely with the Andy Clinic, and we can, you know, make sure that no one's being disadvantaged, and we can get young people and their families the best support that they need as soon as possible. I'm imagining there's going to be some questions on that later, but we'll come back to questions afterwards, I think. Taja.
Hello, sorry I was late in. So I'm Taja, I'm one of the deputy managers for the MHST. So I'm going to talk a little bit about the whole school approach offer that we do. And I think it's a really nice offer because it's all about being holistic and sort of exploring how we can build these supportive and resilient environments to help children thrive, really looking at how we involve families, the school, different agencies, and what the school really needs to help their students in this approach. Sorry. Are you flicking, Katie? Because I just realised that I can't go to the next slide. Thank you. So there's 8 principles to wellbeing, which we kind of run this whole school approach offer of. So Public Health England came up with these, leadership and management to support the offer, make sure that it's running smoothly, make sure that we're getting the right support out there to the schools and the people that are accessing our care. We really want to look at what the curriculum is, how do we promote the resilience and get the right support in there. So that's looking at the external agencies as well as just what's in school. We can offer staff training. I'll talk a little bit about that on the next slide. So there's the ethos and the environment, targeted support, making sure it's the right support, working with parents and carers, like I said, really looking at that holistic offer, identifying need. And I think it's really identifying need before it gets to more of a sort of different issues. We want to look at that sort of emerging mental health. So I think that's a really important part. Staff development and enabling the student voices, which is obviously really important. So how do we go about the whole school approach? So we should have an EMHP or a worker within the school who would do an audit and work with the school and see what they need. And then we can offer assemblies, parent workshops, wellbeing groups, and those would look at sort of exam stress, transitions, managing worries, talking about mental health, the 5 ways to wellbeing, recognising and managing emotions, social skills, friendships, self-esteem, and a lot more. And obviously those consultations for staff as well. But there's a lot that we can do to kind of get that holistic approach. So what we have done is, because I think, as Katie sort of went over, CAMHS is a big organisation, and I think people can get confused as to what service they should be under, or who do they refer to. So what we do as an MHST now is we offer staff consultations to the schools, and these would be a named consultation where one of our therapists would meet with the school, discuss sort of the concerns that they have, and make a recommendation on that. So this slide just talks a little bit about how we would go about that. I'm happy to answer more questions on that later if needed. And these are what we like to have as an agreement with the school. So in order for us to be able to do the work, offer the work that we provide, we need appropriate and protected spaces for clinical work, obviously with confidentiality, thinking about confidentiality, providing desk space so that our clinicians can do the relevant paperwork. We do ask for video recordings so that we can constantly develop. So we ask for that as well. Obviously, that we're involving the children and young people and their families in the future participation, engaging fully with monitoring and evaluation of the requirements that we've kind of set out, understanding what the MHST will do so that we complement what they've already got in place rather than substitute sort of like existing support within the schools. And we do ask that there's a dedicated mental health lead within the school that we can kind of liaise with, which kind of links back to the leadership and management of the offer.
And that is the MHST.
Thank you, Katie and Taja.
So, thank you. Is there anything else you'd like to add without these slides about your service and the way you work? Would you like to talk a little bit more about that, or shall we go to questions?
Should we go to
I can't think of anything. Yeah, I can't think of anything that hasn't been covered. I'm sure there will be.
Yes,
people will point it out to us, I'm sure.
Opportunity for people here to ask questions. I can't see any hands up at the moment, but please do ask a question if you'd like to. I was just wondering myself around the sort of use of digital support that young people can proactively get involved in, and what sort of things you do there.
Yeah, we've got a couple of ways we use digital support. So one of the lovely benefits of being linked so closely with Oxford University and the Andy Clinic is that we working alongside Kathy Creswell and her team to deliver, I guess, but also be part of the research in some of the digital interventions that she's developing. So Kathy Creswell is the author and primary researcher, I feel like Lucy Willits is going to be mad at me for saying that, behind the Helping Your Child intervention, which is what we offer to parents of anxious primary school age children. And they've recently, I say recently, it was a few years ago now, developed a digital and online version of that, and we're lucky enough that we're able to offer that to parents who maybe don't have the time and the capacity to do the 1 hour therapy sessions. That content can be delivered online that they can access in their own time, and then they've got a little bit of therapist support alongside as well in the form of a 20-minute phone call, which is a really lovely way of doing that because all the content exists. In terms of for teenagers and digital support, we have quite a lot of apps that we like to signpost people to, some developed by Oxford Health, others just sort of approved by Oxford Health. And we use those kind of alongside our interventions as well. We were talking about one earlier, weren't we, Taja? Blue Ice, which has a mood tracker, and I think it has some a thought tracker as well, I think, that just really complements the CBT elements of our interventions.
Anyone like to ask any questions? There's one question here. Fatu, would you like to ask it yourself, or shall I ask?
I was just curious to know how you work with diverse communities, like those who struggle with language, because I work with a lot of refugees and migrant communities who don't know a lot about the camps. They talk about the long waiting times and stuff like that, but in fact, the actual service of camps and what they provide, some of our communities, diverse communities, don't know about it. How do you kind of engage with them, or how do you tackle that barrier in itself in terms of language and just raising awareness about the service in itself?
Holly, do you want to take this one, or should I jump in again? I don't mind. Oh, Taja, you're our EDI champion.
Would you like to go, Taja? I'm just mindful I've got to go in 1
minute. No,
Yeah,
that's fine.
Thank you.
Yeah, so I think that we really want to make sure that we are inclusive and that we are bridging the gap so that all kind of communities can get involved. And as this is kind of like a whole school approach, we do work with the schools. So we do have we can use interpreters. We have our leaflet is adapted so that it can be translated to different languages. We have got a new kind of provision at the moment where our CWPs are working more in the community. So that's kind of what we want them to do. We want them to get out there and reach those different communities that perhaps wouldn't access services normally, or wouldn't know how to access the services, to really build that education. And as I say, if there's sort of like those language barriers, then we do have interpreters that we can work with that can use that can help us to get the message out about what we offer. And we really want to hear more from those communities as well about what support they feel they need, which would work with our kind of holistic approach, where we want everybody to be able to use the service.
Can I just add, hi, sorry I was late, I'm Vicky Norm, head of CAMS. Yeah, just to add to that, we identify if anyone's an asylum seeker, we do in our single point of access, identify that very quickly if we know about it. We don't get many young people asylum seekers, but we do identify them so that we can make sure that they get the right care they need as soon as they need it. We do have waits for service, so we do a thorough triage process about who needs to be seen quicker generally. We do have some criteria around that. But yeah, I think we need to improve around who needs our help. I think we need to also remember respectfully that some, I guess, how do I try to explain it, that I know that with elderly care, some Asian families do a lot of their own care, and I think I don't know what we need to do more work around is, what are we missing? Are we missing, or are families looking after their children in terms of they don't need CAMS? So I think we don't have a lot of understanding. I don't think as much as we should have in Oxfordshire, and I think that's something we as a service definitely need to work on.
I think one of the lovely benefits, though, of working with schools and in schools, that it doesn't rely on parents and families being aware of our service. So yes, we are limited in that we only are covering currently 60% of the schools, but with the plan going forward that we will be 100%, imagining for those 60% of the schools that we're in, that those children aren't reliant on a knowledge of CAMS, that the families don't have to be aware, because we've got that link within the school, and the school can go, this might be helpful for you, here we go, let's get this started. And flicking back to the previous question, the digital interventions, with more of these coming about, it is easier to translate and for those to be available to different in different languages. Sorry.
Thank you, that's great. Nikki, you've got a question. Again, I can ask it by reading it, or would you like to ask it yourself?
No, I don't mind asking it myself. Sorry. Just really, we know from the past there's been sort of long waiting lists from CAMS referrals, and just wondering like what impact that has on you guys as in MHST, something that could have started off as quite a moderate by the time it's been referred and has gone through referral process, which has been very long at some point. Does that then change? I mean, how are you sort of combating that, or is there an answer to it? Are referrals getting quicker, or yeah?
Yeah, great question. To a certain extent, it's a little bit, how long is a piece of string is how long are the waits. We are working on it, absolutely, and we've got some really lovely data to show that our waits are reducing. We're doing this in a couple of ways. One is with increasing our sort of universal offer. So going out to schools ahead of referrals and going, let's do this piece of work together. Let's do this workshop. Let's invite families, etc., etc. So that hopefully we can preempt those referrals and actually maybe prevent the referrals from coming in. And we have seen a really positive impact of that. Our wait times have come down massively. The other way that we're working on this is in terms of sort of doing groups within cases, families that have been referred. So yeah, getting people the interventions they need soonest. In terms of how it impacts, yes, we have in the past had referrals come in that are mild to moderate that then actually have become more difficult, more impactful, and they are really tough to find out and decide, what is the best option for these families. On the one hand, we want to be able to provide something because they have been waiting for our service. On the other hand, we do have to make sure it is most appropriate for the families, and it really is on a case by case as to how we proceed. For the most part, I would say we are offering intervention to the families that have been on our wait list. The issue is then that perhaps it doesn't have the full desired effect, but at least they're having, some intervention to start with. Sorry, Vicky, I spoke over you.
No, I was just going to say, no, it's fine. I was just going to say we're doing a lot of work, a lot of development work, so that we're changing a lot of our model so that we so there's MHSTs, and also when families come into the single point of access, they can access our new supportive steps model, which is a lot of online interventions and some groups for families, for the parents to actually understand the basics of mental health, what we offer in CAMS, and actually if they then need more help, they then can get more help, rather than we're trying to basically reduce people having to wait generally. So we're changing the style in how we're doing things to actually mean we get more people through. And some of the pilots have been actually that families have done that, and they've said, actually, we don't think our child needs your help now. We can kind of manage with the information that we've got from you, which is going to be really helpful in terms of, we have what we have in terms of our, we have obviously very long waits for neurodevelopmental conditions, but some of our services don't have waits. We don't have waits all over our service, but we're just having to basically be creative with the amount of money we've got and how we deliver services to everybody. So it is a challenge. I'm not saying it isn't a challenge, I guess, but we are kind of striving constantly. We are also implemented the new Sharon. Sharon is a parent peer support, which is a monitored. It's like Facebook for parents, but it's specifically for the areas of our service. So our parents can interact, but also we can monitor it. So we can monitor and give advice, etc., to parents, which we've also implemented in the last 6 months. So we're trying to put a lot of support in as well, not just that people have to wait, but there is things if they do have to wait. I hope that's helpful.
Thank you. And Lizzie Moore, you've got a question which sort of incorporates the wider things around prevention for mental well-being, such as being involved in green activities, green spaces, and the sport and active Oxfordshire opportunities. Lizzie, do you want to actually ask your specific question, or shall I read it from the chat?
I'm happy to ask it. My name's Lizzie. I work for Oxfordshire Local Nature Partnership. My background's in public health. and I was just curious to know whether within this MHST model there's been any consideration around how to incorporate social prescribing for that kind of wider support for children, young people, and maybe families as well. It's something that I've seen through my work in other areas where social prescribers are based in schools to support their mental health offer. So just wondered whether that been considered in Oxfordshire.
So being honest, we have some social prescribers in some of our services. We don't have them in our MHSTs. We have been working with Response to have a youth work offer within our MHSTs. However, that is the contract's coming to an end at the end of March, and actually we're not renewing that. And the main reason is schools want evidence-based practice. They want the treatments. We're not kind of early help as in pre-CAMS, and they want the children to have the treatment. So that's really where the push is for us, is the wait for treatment. So we would love to do much more in terms of prevention, but that's not what we're commissioned for. So we have to kind of focus on the mental health. I know one of our youth workers has been doing a project with children with the Ashmolean Museum, which has been lovely in terms of getting autistic young people out there and trying to kind of get them interested in things. But that's kind of still focusing on the mental health. We haven't got the resources, sadly. We've got so many waits for the actual treatments that we don't have the resources. But we do. Youth work's really valuable and really works in teams that have multidisciplinary teams which work with really complex young people. I think it really works well, and we have youth work in some of our other teams, and social prescribing has been really successful in some of our other teams, alongside kind of the clinicians that then treat the mental health problem. So it is great, but unfortunately we have to just put the resource where we can, because people want the treatments, if that makes sense. Hope that helps.
So maybe following on from that question, because prevention is one of the big shifts we're meant to be seeing with the government, and there's a lot of focus in Oxfordshire on that with, as I said, Active Oxfordshire and other, community-based offers. And I just wondered, how do you link in? Do you actually, can you refer people on or link them in, or just at least highlight that those are out there?
Yeah, I mean, we do a lot of work in our single point of access to actually triage. We spend a lot of time triaging cases and then signposting them to other voluntary sector agencies. We're also looking to do a piece of work with public health around, 47% of the work we do in our single point of access isn't for CAMS. So actually what they're very interested in is looking at what did help, though, what those young people do need that isn't us. So we are kind of involved, but also, again, we keep having to remember what's our business and what's other people's, because I think sometimes, especially in Oxfordshire, CAMS get seen as, because we do the whole of the neurodevelopmental pathway, so we assess young people that haven't got mental health problems, because the way we're commissioned, we get seen as kind of CAMS do autism, CAMS do everything, and of course we don't and we can't. So we are involved, but obviously we can't do everything, unfortunately. Sorry, I don't know if Taja or Katie, you said something and I was
going to jump in and sort of compliment that, I guess, Vicky. Obviously that's great. At the point at which a referral has been made, and what we're rolling out in the schools is this consultation model, which in my experience works beautifully, and I hope the schools would agree with me as well. We have had some really lovely feedback on it, where actually schools are coming to us and before that referral goes in are saying, what here is what's going on for this young person, and a bit of family background information, etc. And even before we get to the door of SPA, we can say, actually, here's this really great charity that works specifically around X, Y, Z. And yes, sadly, the Response contract has come or is coming very shortly to its end. But we have a knowledge and an understanding of what little projects are going on out there. So there's a lovely sort of Lizzie's point about being out in nature and so on. There's an arboretum project that's running at the moment that's had a lot of lovely feedback. With school non-attenders being able to get out there, and I think it's really focused on the 5 ways to wellbeing. So we are able to get into schools and share that knowledge that we have about these other agencies, charities, organisations with the schools, if MHST isn't indicated.
Yeah, and I think as well, to add to that, schools are really really on board about how important it is to get children outside and how that can really improve their well-being. And a lot of the schools were linking up with other agencies, and they're introducing like forest schools or more outdoor learning. And I think that that is something that we might not offer within the MHST, but we absolutely appreciate how important it is, and we want to support that. So we do refer to external agencies as well, and the schools are really on board with that.
And it goes back to that slide in the presentation, isn't it? We are in the schools to complement their existing offer. You know, we're not looking to take over we're not looking to add any more work for ourselves. If there's something that's as good or better at this, you know, desired outcome that we are, then brilliant, let's get alongside it and let's get supporting that and that implementation.
That's great to hear. Has anyone got other questions? I was wondering, I'd really just like to hear, you know, you give some example of maybe somebody you've worked with in an anonymous way, but just, you know, how that's you know, helped them and supported them, and what floats your boat in doing this type of work, why you love it.
I mean, if you bear with me, I can find you some patient journeys, I think. Oh no, I can't remember what it's called. Taja, can you remember what it's called? That PowerPoint that Leslie's done.
I know. Is it in? Because I was just thinking, if we go through it all, it'd be amazing, wouldn't it, to get some of the feedback.
For example, I came across a case today. I was just auditing some data because that's what I do in my spare time, and we had an email from a young person who had completed their therapy sessions, and they emailed in to the therapist that they had been seeing to say, I've asked my mum if I can email you because I really wanted to let you know I went to Harry Potter World, and that was one of their goals that they had for therapy, was because they were just so overwhelmed and anxious about going places with lots of people, and they'd emailed into the service to say, I did it. I did it. I went to Harry Potter World. I had a wonderful time and nothing bad happened. And it really is just little things like that, where it's, you know, demonstrates that children are claiming their lives back and able to live them sort of unlimited. And that's what does it for us. I think all of our teams, and it will be things. A lot of our referrals come in for primary school age children, so we do a lot of work with parents, and it will be things like parents saying, my young person slept in their bed all night. And, you know, we go, okay, well, sure, most people might be doing that, but for that family, that's huge. That is huge. And those parents can get a quiet night's sleep, and everybody's better regulated once you've had a good night's sleep. It's little things like that. We are very goal-based. We get lots and lots of data from lots of questionnaires, which obviously we use in ways to evidence that it is or isn't working. But actually, the families and children and young people set their own goals. What would you like to achieve by the end of these sessions? You know, what would you like to be able to do that you don't feel like you can do currently? And the bonus for us is seeing them achieve that, and getting their lives back on track to where they'd want to be, going to sleepovers, putting their hand up in class, getting back into lessons. We get quite a lot of those, don't we, Taja? Lots of people going, you know, school attendance is improving, etc., etc. But yeah, if it is helpful, we can find you a couple of slides that therapists have put together following the end of their treatment, and we can I'll either pop them on the end of this PowerPoint, or I'll send them over to you separately. Should be all anonymized, I hope.
So we can share that on our website. And any links, other links. Any more questions? Anyone else like to ask a question? If you haven't been brave enough, you can ask a question, or again put it in the chat. So I was just wondering, for parents who are you know, dealing or struggling with some of these issues, but where is the help that they go? They go to the CAMS website, or where do they look for help, and where to go navigating all of this?
So they can go to the CAMS website, or they can go to their children's school and get a referral in that way as well.
We also have if we have a Walking With You support group, which is online, and it's just started doing face-to-face coffee mornings, and it's doing one in each area of the county, so they can access that. And we have the new Sharon platform, which is the online platform that they can use. There's one for specifically for NDC, and there's one specifically for getting help and getting more help. And that we're just rolling that out now, and we're getting more popularity about it, which is great. Also for families that are waiting for an NDC assessment, a neurodevelopmental assessment, they can access the Living Well with Neurodivergence, which is a program that they can all access. We encourage them to do that and not just wait for the diagnosis.
We don't very often get referrals directly from parents. Most often in the MHST, they come via schools. On occasion, we get a parent or two contact SPA directly. But what we will do is we will get the family in together for an assessment. We don't very often work exclusively with the young people. We will almost always, I think there's probably some exceptional circumstances, almost always get the parents involved, and we'll get their perspective on what they're seeing and how things are going at home. A lot of our interventions have like a parent session or a couple, or the parents will join for the session. I think I'm thinking of BA, where we've got, which is behavioural activation, sorry, another acronym, which is our intervention for low mood and depression. And I think it's 3 out of those 8 sessions are parents are involved as well, because we're so aware of the systemic factors that impact mental health for children and young people. It is so important to get parents on board, but also for them to be able to get a little bit of support for themselves. So yeah, there will be occasions where we signpost families, parents out to different organisations as well for support for themselves. But there's also lots of resources and reading and self-help that we can signpost.
That's great. So the other thing around what the work of Healthwatch Oxfordshire does is we listen to people using health and care services. So we've got a thing on our website where you can leave your feedback on any service that you use, including the CAMS service. And then we make sure that providers or decision makers hear those voices as well. And we do more specific pieces of work. So just we've also got lots of information on there as well, so that'd be a place where people can go to see that. We've got future webinars coming up. The next one will be in May. We haven't quite decided our topic on that, but please keep an eye out with our newsletter and sign up to our newsletter so that you can see what's going on. So last chance for questions, and I think we'll wrap it up there. If
I think Dilber's got a chat.
Sorry, where's that then? Gail, is it?
Dilber.
Dilber, would you like to ask a question?
You're on.
Yeah.
You're on.
Hiya, sorry. Hi everybody. And I want to ask about the question you're talking about a coffee morning or area. Do you know where it is you can do it? Possible we can know about detail. I want to be including. I come to the about
which child is your which service is your child in?
My child is in the school. Yani for everyone or for normal? Yani they have to show the problem or.
It's the coffee support group is for the families already seen into children in our services. Have you got children that are in camps?
In our service I have my child. She had operation. She have some problem with some problem. We going to the hospital always coming, but I'm not with any service.
Okay, no, it's a mental health service. It's the children's mental health service.
Dilber, I think what would be good is if you would like to email us.
Yeah.
If you can email us, we will pass your query on.
Could you send me the email? I will.
Yes, I'll put the email in
Yeah.
chat. Yeah.
If possible. Yeah. Thank you so much. This is a very good the program. I really want to enjoy it. That's why, because I come is beautiful. Do you know, talking about children is yani sometimes we our body health looking at, but mental health is very important. Yani is like if mind is not healthy, how we can future is no good coming. Do you know? I really like
Absolutely. Yeah, for sure. So the MHST also do coffee mornings on occasion. So look out for these in your child's school if they're at an MHST school. Yeah, you got two options. Either you can sit and wait for the school to say, let's do a coffee morning, and then we'll put on a coffee morning in the school, or you can do it the other way, where you can approach the school and
But
say,
we have a coffee morning in the school. Sorry, but is not talking about something like that. They just have a coffee morning. Yeah, just have a coffee morning, but they talking normal about children, but they didn't talking about special with NHS or with some specialist. We have coffee morning, but this is a different, I think.
Yeah. Sorry, Katie, you carry on.
No,
okay, sorry. Thank
no,
you.
I was just gonna say, I think if the coffee morning is run by the MHST, then we would kind of have a theme around it. So we would be looking at talking about children's mental health. I think on our slides we've kind of got the schools that we cover, so we can have a look if your child's school is on that list, and definitely would be more than happy to get in there and run a coffee morning, because I think it's something that really helps that kind of peer supervision between parents as well, and getting to know other parents, and that's really important.
Can I just follow up on that question? You talked about some outreach into communities, particularly communities who might not engage in other ways. Are there possibilities that you can visit groups and have sessions in community groups?
So this is kind of like an emerging offer at the moment. It's new, where we've kind of got this new role, CWPs, where we want to get them more out into the communities more, but that's certainly what we're looking at doing sort of in the coming months. So yes, that's on our radar.
Okay, we'd be really happy to support you with linking up to groups or promoting that.
That'd be really great.
That would be amazing. That would be great. Yeah. Watch this space, and let's stay in touch. I love that. I've just popped in the chat the link to the CAMS website, which has got, I think there are some little inaccuracies on there, so my apologies for that. I don't actually know how we get the website updated, but it's happening. There's a couple of little errors on there, but for the most part, it's got the list of our MHST schools on there. So if anyone in the audience today is a parent and they're going to their school and saying, are we an MHST school? If the school doesn't know, that's a little bit of a problem. But you can always check this list on this website. And yeah, if your school is on there, get in contact with the senior mental health lead or the SENCO, and get them to get in touch with us.
Okay, well, thank you so much.
Thank you so much. Thank you so much. You give me answer. Thank you.
And Dilbo, we've put the email in the chat for you to follow up with your question, and I'll pass that on.
Thank you so much.
Yeah, so look forward to hearing from you. So yes, thank you very much. It was a really interesting session. We might get you back at another time to talk about something, in the future as well.
Anytime.
Please do keep in touch, and
of course.
Let's keep in touch. So thank you very much, and thank you.
Anytime. All right. Take care. Bye-bye.
Take care. Bye-bye.
Thank you so much for having us. Bye.